The third presentation, last of this session, will be about EGP, Eosinphilic Granulomatosis with Polyangiitis. It will be presented by Dr. Emilio Pizzichini, if I'm right. I'm Professor of Medicine at the University of St. Catherine, visiting professor at McMaster University in Canada.
Hello, it's a great pleasure to be with you today to speak about the role of mepolizumab in the treatment of a very uncommon but important disease that is EGPA. My name is Emilio Pizzichini. I am professor of medicine in Santa Catarina, south of Brazil. And I have been involved in many research about the treatment of biologics in patients with severe asthma and EGPA. So EGPA, it's an uncommon disease. It's a systemic disease that the main feature is vasculitis, necrotizing vasculitis, and it has been treated commonly with courses of oral steroids, or in the other case by other kind of systemic treatments like cyclosporine. And we are going to present today some data about the use of a monoclonal antibody, which is mepolizumab Nucala, which is given in doses of 300 milligrams, so 3 vials per injection every month in the treatment in patients with EGPA. And the clinical benefit of mepolizumab, in short, is you are able to increase the time period of remission, to decrease the dose of oral steroids that these patients need to be maintained, and also to increase the time that are free from relapsing of the condition, which are the main feature of this disease. So I will start with the study design, which is the Mira Study, which is a study that's done around the world in patients with EGPA that had been uncontrolled tissue involvement. OCS are the cornerstone of treatment of EGPA. However, they are not optimal due to the side effects that you have either with the courses of oral steroids or with the chronic and constant use of this medication. The cornerstone in the pathophysiology of EGPA is that you have infiltration of eosinophils in several tissues and a high number of eosinophils circulating into the blood circulation. Usually the blood numbers are increased of higher than 1,000 per ml, and mepolizumab is a monoclonal that is able to block IL-5 and avoid the proliferation, activation, and survival of eosinophils in the circulation, and also decreasing the amount of eosinophils in the system. So the objective of the Mira was to investigate the efficacy of mepolizumab against the standard treatment that was placebo plus all the treatment that the patients have been used in a study period of 52 weeks of evolution. So this is the study design. So patients have been seeing the baseline and they have been randomized in 2 options. Mepolizumab 300 milligrams or placebo, and the follow-up was 52 weeks. And there was a rate of 1-to-1 in the treatments of mepo and placebo add-on treatment. So the rationale for the use of mepolizumab 300 in this population, mepolizumab is approved in the treatment of severe asthma with a dose of 100 milligrams. However, to assess the efficacy in EGPA, a higher dose, 300 milligrams, was chosen because this dose is able to reduce the number of eosinophils around 85% against 70 6% when you use 100 milligrams, because so we want to use a dose that had higher percentage of reduction of eosinophils that was similar to the dose of 750. So the outcomes of the study were total occurred weeks of remission and proportion of the patients with a remission at weeks 36 and 30 and 48. And also secondary endpoints were time to first relapse of EGPA and proportion of the patients that they need to use steroids in weeks 48 and 52 according to the dose 0 to 4, 4 to 7.5, and higher than 7.5, and also addressing the safety of this medication in patients with GPA. The inclusion criteria show patients should be older than 18 years of age, have had the diagnosis of EGPA for higher than 6 months, taking a stable dose of ICS, the OCS, that was higher than 7.5 and lower than 50 milligrams per day, with or without immunosuppressive therapy, at least in the 4 weeks before the treatment. They should have excluded if they had a microscopic polyangiitis, say if they had a life-threatening condition of the EGPA the last 3 months, or if they had granulomatosis of Wegener in the beginning. Who were the patients that have been selected for this study? So here we have the features of 132 patients, 68 in each group. So the mean age was around 50. The most frequent group were females. ANCA positive happens in 10% of the patients. The absolute number of eosinophils per millimeter was around 1,700 eosinophils, and the mean dose of prednisone in this population was between 7.5 and 50 milligrams of prednisone. And 40% or 30% of the patients were using at baseline immunosuppressive treatment in the situation. What is the AGPA situation in these patients? All the patients had asthma, which is an inclusive situation. Around 40% of the patients, they had biopsy evidence of vasculitis. Neuropathy was present in 40% of the patients. 70% of the patients had pulmonary infiltrates. Sinusonasal abnormalities were seen in the vast majority of the patients, and you can see the other less frequent proportion of the comorbidities that those patients have here in the situation. So the mean time for the diagnosis until the entering the trial was around 5 years of the diagnosis. And most of the patients that they had a relapsing condition in 75% of the situation. What are the results of this study? So this is the time for accrued remission. So you can see in the red dots the patients that have been randomized for mepolizumab, and in the gray dots the patients that have been randomized to placebo. The end of intervention was 52 weeks. So the probability for the patients to be a remission was 6 times higher using mepolizumab, with interval coincidence between 3 and 13, higher, more frequently to have remission. So the accrued time for remission was significantly greater with mepolizumab than with placebo. And 32% of the patients in MEPO versus 3% of the patients in placebo had remissions at both weeks 36 and 48 weeks that were also endpoints important in this study. There were other secondary outcomes that have been analyzed. Most of the patients in MEPO group, 19%, had remission in the first 24 weeks and remained in remission until week 58. And this only occurred in one patient in the placebo group. So there is a huge difference. So achieving a remission and also maintaining the resolution, this remission during 24 weeks. Among the patients that had a eosinophil count higher than 150, 33% of the patients on mepolizumab against 0% of the patients on placebo showed remissions on 24 weeks or more. So what was the time in relation to the first relapse, so the first reacutization? And then we have in gray in the upper corner placebo patients, and in red in the lower corner patients that have been treated with mepolizumab. So the hazard ratio has been decreased by 70% in the patients that have been treated with mepolizumab in comparison with the patients that have been treated with placebo. So the annualized rate of relapse was 1.1 with mepo and 2.3 with patients with placebo. So there was a 50% reduction in the annualized rate of relapsing in the patients with mepolizumab. In relation to the proportion of the patients that need to use steroids, 80% of the patients they finished the study needing 0 milligrams of prednisone, between 0 and 4%, 4 milligrams, 26%, between 4 and 7.5, 50%, and 7.5%, 41% of the patients had to still use more than 7.5 milligrams. It's very important to address here that not all patients are able to reduce the full amount of prednisone, because in many of these patients using prednisone for more than 5 years, they have an oral dependence and with adrenal insufficiency that prevents those patients to go to 0 milligrams. So 44% of the MEPO patients against 7% of the patients in placebo were able to reduce more than to less than 4 milligrams in the dose of placebo. There are some post hoc analysis of the studies to find out a little bit more what else beside the main objects of the studies here. So the clinical benefit, they defined it as one here, is remission at any time during 52 weeks, higher than 50% reduction of the dose of oral steroids, and no relapsing for 52 weeks. And you can see that in the patients that used mepolizumab, we've seen this benefit in 78 of the patients and in 32% of the patients that have been used or treated with placebo. So the higher is the count of eosinophils in circulation, the higher is the response, the higher is the prednisone the dose. Is the prednisone the dose is the higher the response, and the higher is baseline weight, is the higher is response into relation to placebo. I'm going to pull out this result here. So, and here is the greater accrued time in remission when you have more than 150 eosinophils. So I have shown this data before. 33% of the patients in mepolizumab against 0% of the patients that have been treated in placebo. So what about the side effects of this intervention? So the treatment with mepo 300 milligrams was very quite safe during the treatments, and there were no significant differences between the placebo group and the patients treated with 300 milligrams. The adverse event that were being considered due to the trial agent occurred in 3 patients with mepo and 3 patients with mepolizumab. And there was a higher incidence of reaction in the site of mepolizumab than in the site of placebo-treated patients, but overall the safety of the intervention was very good in the patients treated with mepolizumab. So in conclusion, I would like to say that the intervention with this with mepolizumab that has been approved for the treatment for EGPA in several countries is that you are able to reduce or get a remission that it's higher than when patients are treated with placebo, that you are able to reduce the dose of oral steroids by the end of 48 or 52 weeks of the treatment. You are able to reduce the burden of oral steroids by 50%. Some patients who do not achieve remission, they also achieve other benefits as defined by composite endpoints, and mepolizumab was safe to be used in this population and is the first drug to be licensed for the treatments for EGPA around the world. With this, I would like to finish my presentation that we still have some limitations in the treatment for patients with EGPA, mostly in patients that might be ANCA positive. However, we understand that GPA is a heterogeneous disease that has vasculitis, has the main pathological feature, and that mepolizumab is a good option to treat patients that have oral and immunosuppressive dependence. Thank you very much for your attention and have a safe journey.